Okay. Hello, Sam. How are you today?
Hey Clint, how you going?
Well, thanks.
I'm
So
good.
today we are talking about shin splints. So I guess obviously the first question is most people have probably got some feel for what shin splints actually are. Could be right, could be wrong. So let's start off by talking about what shin splints actually are.
Well, shin splints, Clint, it's an umbrella term, really. Shin splints for it. Usually, we use that for pain along your shin, which is the front and inside part of your leg, or the shin there, the tibia bone. That's typically all along there. You can get a number of different sort of pains around there, but we sort of bundle them all together and refer to them as shin splints. So someone will get pain in their leg, typically on the inside, and we'll call that shin splints. The most common type of shin splints, though, or the most common pain that you get in that area is something called medial tibial stress syndrome, which is a pain along the anterior medial aspect of that tibia, which is that front inside, the lower third, typically just above your ankle. So between your ankle and your knee, but typically it's in that, if you divide that up into three, it's typically in that lower third, so just above your ankle.
Now, you've said there's a few different types of, it's an umbrella term. So, and you said this is the most common one. How common is it? Does it account for like 80% of shin splints, 60%? What sort of?
I'd say clinically, it account for about 80%.
80%. All right, so if somebody says I got shin splints, then it is very likely to be, and I've forgotten the name of it already. What was the name of this condition?
Medial tibial stress syndrome.
Medial tibial stress syndrome.
Yeah.
Gotcha. So
that's
are
most
we going
likely.
Right. So are we going to focus on that when we talk about shin splints, or are we going to talk about some of the other types of shin splints, or is that sort of is this a topic in its own right that we should focus on today?
Yeah, I think it's a topic in its own right, but it's I think it's the sort of go-to diagnosis that you're looking for when somebody's got shin pain, and you've got to then look for things that are not medial tibial stress syndrome. So because it can be other things in that area, of course. Shin splints or medial tibial stress syndrome, more precisely, is probably on a continuum. So yeah, if you imagine it's, a little bit of the stress through the tibia there, but it can also progress to things like stress fractures through the tibia. So you don't want to miss that. You don't want to be treating a stress fracture like you would just a stress reaction, for example. But there are other things like compartment syndromes in that area. So there are different things that you'd need to look out for. But typically you're trying to use, your starting point is medial tibial stress syndrome until you've proven otherwise clinically.
And you just said there was a spectrum. So it can get very severe as well, but you would still consider it part of that same medial tibial stress syndrome. But then there are some things that are just completely different. Is that correct?
It can progress. So the stress in the bone can progress to a stress fracture, for example.
And would that still be considered essentially somewhere on the spectrum of the medial tibial stress syndrome? Or is that then now considered a different condition?
Well, it's a different condition. It becomes a stress fracture, but it's so the spectrum would be the bone stress or the bone injury. So the bone injury can be a little bit of overuse, a bit of stress, a bit of remodeling, and so you get some bone bruising, as we'd call it, or a stress reaction. And then that, if it's treated well, that will subside. If it's not treated and you continue down that spectrum, or you continue down that continuum of stress, then it'll overwhelm the bone's healing capacity, and it'll become a stress fracture, for example. And if you keep going, so that's where we want to watch out for different things like that, or you want to rule things out like that if you need to. But typically, when somebody comes in with just pain along that inside area or the inside lower area, especially. We're looking at, we think, medial tibial stress syndrome, and then we've got to try and prove otherwise, or rule out other conditions.
And speaking of medial tibial stress syndrome, for what I've picked up there, it is very much a bone thing. It's about the bone. Gotcha. Yes. All right. So tell us what's actually going on with the bone then.
Well, two theories actually, but they're both bone related, and they bring into perspective things around the bone, so that things that attach to the bone. Over the bone, we've got like a very fine layer, like a bone skin. For the purposes of this conversation, we'll call it, a bone skin or a wrap around the bone. That's called the periosteum, and so that's a lining over the tibia. That can get inflamed, and usually there's two schools of thought there. One is that it's a traction injury or an overuse. It's definitely an overuse thing usually, but it's it's usually a traction of muscles and the periosteum. So at that interface, muscles are pulling away. This is one of the theories, that muscles are pulling away at that bone if they're a bit tight or they're working harder. And as they're pulling away where they insert onto that bone, that periosteum then becomes inflamed, and that's where we get the pain from. That's one theory. The other theory is that it's not actually muscles that are involved; it's just purely bone, and it's as we overuse the tibia, or we start running a lot more, or we put a lot more impact on, basically. And there's many things in that equation. But as the forces that are generated increase, we get compression of that inside of the tibia there. We get compressive forces there, and then that causes the bone stress. And typically, either way, what happens around that area is that as the bone's trying to remodel, the bone remodeling to handle the stress around that tibia, it doesn't happen quickly enough for the amount of activity that the person is doing. So then while we're in that phase, we get this stress syndrome along that border.
I just want to
clarify.
That's
typically how it happens.
Sure. Now, when you say remodeling, a lot of people are probably thinking of their homes. But what you're talking about here is the bone is actually, I guess, growing more in some regions, maybe even doing the opposite of growing and shrinking in other parts. It's essentially changing its shape to accommodate the new stresses that it's being subjected to. Is that correct?
Yes. Yeah, gotcha. Exactly. So our body deals with stress and forces in that way, so that we've got adaptation where it's sort of like the use it or lose it, or your strength training at the gym. You're sort of stressing something beyond its capacity, not enough to injure it fully, but to introduce some micro injury, and then the bone, in this case, the bone would be remodeling and adapting so that it can then withstand that sort of stress. Now, if that happens at a rate that is equal to the amount of loading, then everything's fine. If it happens too slow for the amount of stress that we're putting on, then obviously its capacity to withstand those stresses is reduced, and we then introduce the right sort of environment for a bone injury such as shin splints, or an overuse bone injury such as shin splints.
Now, I just want to touch on something. You said there are two theories, which I find interesting, because I guess a lot of people don't realize that there are things we don't know as humans and out the world around us. And that's a bit shocking to some people. Do you have a preference on one of those theories? Is there one that sort of you feel is more likely to be the winner than the other? Or you actually think there could even be a third theory?
Yeah, well, there could be more, and as imaging gets a little bit more sophisticated, we're seeing a lot more, and that's where that second theory came from. It was more when we start looking at imaging, people say, oh, well, actually the muscles aren't really inflamed, or there doesn't look to be tightness in this area, where we would usually think if there's a traction injury there's going to be tightness of this muscle, but we're not actually noticing that. And so the bone compression theory then takes over.
That's the new kid on the block.
That's the new kid on the block.
Right.
But I think for me personally, I don't subscribe to one and disregard the other. I would see they both make sense from a clinical perspective, but you've got to be able to apply one to a certain person. So if somebody came in, for example, with tight muscle groups in that area, and that was you could very plausibly say that's a contributing factor, and we're going to treat that. We're going to include that in the treatment plan. If it's not at all, then I would go the other way and say, okay, well, I think that, that's not a big enough factor in this condition or in this presentation to be able to include that in the treatment program. I'm going to go more down the compressive forces.
Gotcha.
The beauty, though.
Yeah, sorry. Go ahead. I was going to say, to me, it seems, sorry to cut you off, just to get this out there. So it seems it's quite possible they're both correct, but we've got different types of shin splints. And we just need to realize that. But I guess the other thing here that's interesting is if anybody has shin splints and they get the opportunity to be a part of any research project, then they'd probably be doing humanity a favor by helping us collect more information. So if you do have shin splints and you hear of any research project, get involved. And I guess you also said something there that was interesting, was that you're using these different theories to help guide your treatment. So I guess even though we're not 100% on what shin splints are, or their precise nature, we still do have a very good understanding on the kind of activity that results in shin splints. And I'm assuming we feel pretty confident in our ability to treat them. Is that correct?
Yes. And the other thing to that is, even though they're two theories, there could be more theories. The end result of that theory is, there's big overlap there. The end result of that theory is that they both, we're certain what shin splints are at their essence. We know that it's an overuse thing. We know that it's stress along that medial side of the tibia. So it's a very defined, a very well-defined diagnosis. But what causes that, or what contributes to that, in reality, it may be multifactorial, and it may be just similar to how we've spoken in the past about plantar fasciitis and fasciosis, and bundling it up into plantar fasciopathy, for example, because sometimes we have inflammation there, sometimes we don't have inflammation there, but they present very similarly, and we know the structures involved, we know what causes that. It's about understanding, or I think just adding a different layer to our understanding through these different theories and being able to apply them, rather than just taking one and saying, well, I have to go this way or I have to go that way. Because at the end of the day, clinically, what you're seeing is the same thing. It's just, it could be explained in a couple of different ways. And the beauty of having more than one theory available is it gives you more than one way of approaching the problem, and more than one way of understanding what's happening for that particular. Because the other thing is that it's very individual. So you really have to make it fit the narrative that you have while you're looking at an athlete or a person that's presenting with some sort of shin splint. You've got to be able to make that story make sense. And you've got to, so having more theories at our disposal is really only a good thing for that.
Gotcha.
Because we can put it into the context of that person. Whereas if you looked at it from only a, for example, it's a tight muscle that's causing this, or something like that, and then in that person that didn't actually eventuate, you did your clinical testing and it wasn't a tight muscle, you could easily just go the other way if you didn't have these other understandings of, okay, well, it's not a tight muscle, but it could be this and it could be that and it could be that.
Gotcha.
So it's a good thing to have.
Yes, indeed. That's a very good perspective. I think that's for those people who might be a little bit concerned when they hear any kind of a health professional start saying, well, we have a number of possible explanations. That's actually a good thing, because in a sense, it allows them to better tailor any treatment to that individual. So on that topic, so how do we treat shin splints?
Well, we as we sort of touched on, it's very individual, because it really depends on what's happening. So we know that at the highest level, we know it's an overuse thing. So something must have changed for this additional loading to happen.
So can I just ask quickly then, does that mean people are very likely to be just living their life as they always have, and then one day wake up with shin splints? They have probably changed what they're doing in some way, and now they have shin splints. Is that fair to say?
That's more likely. So if you woke up and you had shin splints, that would be, as I was saying earlier, that wouldn't fit the narrative. Yeah. So I'd have to look deeper into that and say, okay, well, why would we just wake up and have shin splints? Now, usually for medial tibial stress syndrome, it's not enough force to cause a fracture. So, for example, when we were talking before about that spectrum or that continuum, when we're at stress reaction stage, that's slight overuse over time. So you're getting micro trauma building up. It's not enough force to cause a distinct acute fracture, for example. So that would happen more if there was an impact injury, for example, would be a lot of force loading, and then that would present as a fracture. You'd skip that whole overuse part, so that would happen, for example, in a tackle or something like that on the sports field. But pain that's sort of inflammatory in nature, that is creeping up, that would be more akin to the shin splint sort of diagnosis. So when we see a person with, especially medial tibial stress syndrome, when we see a person present with something like that, we're then looking for things that are happening that are supporting that diagnosis. So it's very much a clinical thing to start with, and it can even be self-diagnosed, like we're saying, pain in that lower third on the inside part of the leg, just above your ankle. You can touch around the bone there, like we're saying, it's mainly bone, or mainly at the interface between the bone and the squishy part, which would be the tendinous attachment and the muscle. But usually it's going to be sore at the start of an activity, for example, and then it might sometimes warm up and go away, and then it will come back towards the end of an activity or when they've rested or the next morning, so you're getting a bit of tenderness. Sometimes it's there throughout the whole activity. And then as it progresses, it's there just when they get up in the morning and they're walking around, it's, sort of in their everyday sort of life. So that progression is what we're looking for. That's that typical overuse thing. That would lead me down that path rather than, is it an acute fracture, for example? Whereas an acute fracture might not present with that diffuse pain along that whole, lower third or that whole inside border of the tibia. A fracture would be a lot more acute, and it would, would just happen, like you said, woke up one day and it was sore, or was playing one day and it got really sore. And it's a lot more focal. So it's typically we call that, a hotspot or something like that. If you've heard people refer to that.
Yep.
So it's a lot more focal pain rather than a diffuse sort of area.
Right.
Gotcha. That's what we'd be looking at there.
Gotcha. And so from the sounds of it, it's almost a bit more like it's more like an investigation into understanding what's likely to have caused it. And if I've understood this correctly, it's really just a case of winding back on that specific activity, or is it tuning that activity so it doesn't put as much load upon you?
Yeah, that's one of the, that's definitely a big part of it, Clint. So winding back activity or telling someone to rest is usually not a good thing, because like we said, we still want that stress to be able to model and for the bone to be able to withstand activity. We're just buying time if we're resting. And usually that would be, the resting part would be if we had a fracture, for example.
Right. Yep.
If we've progressed that far, or we're sort of very close to a fracture. In reality, we don't know where on the spectrum the person is exactly, but we know they're in the phase where we're not quite a fracture, or we know they're in the phase where you've crossed over that and it is a fracture now. So depending on where we see the same injury, you could have two different diagnoses. But if we're looking at it from the perspective of it's still not a fracture, we want to rest because we want to introduce some healing time for the bone and remodeling time for the bone. Absolutely. So we do what's called relative rest. So it would be modifying an activity. So we're modifying the load. We might be introducing rest days, for example. We might be delaying just delaying for a few days or a week or something like that to get some initial healing. And then, we can then reintroduce that person back to sport or back to an activity. But we have to look at different factors. And because we know that it's a bone injury, in its essence, really, it's an impact overuse thing. So what we're then looking at is what surfaces are we training on? What's the frequency that we're training at? What's the intensity that we're training at? What shoes are we wearing? So making sure that we're using the right type of shoes for the activity, very important, because different shoes have different stiffnesses, different support, different cushioning properties. Is the shoe perhaps too old? Is the shoe the wrong type of shoe for that person's foot type? So there's those extrinsic things like running on grass compared to running on sand, compared to running on concrete, compared to basketball, tennis, all those different sports, and how quickly have they increased their training load. So usually it would be, for example, we'd see shin splints very, very commonly in the clinic in a return to pre-season, for example.
Right.
People have had a bit of time off.
Gotcha.
Gone back to hard grounds, and they've just done a lot more activity. And so that's typically where we're going to see that sort of thing.
So I guess that's good to know that it's not the end of your physical activity. It could be, you've got so many things to choose from. You could look at changing frequency, the shoes you wear, the surfaces you train on, or the duration on different surfaces. And there are quite a number of things you could do to let yourself keep on training and overcome the shin splints. But you also mentioned pre-season. I guess shin splints a reminder that maybe it's good to not get lazy in the first place.
Oh, well, yeah. Well, it really just depends on, the sort of circumstances that you're in. If you've had a large training block to finish the season, for example, we still need to give our body some time to recover. But it's that reintroduction to activity, I think, is that shifting back into that mode. If you've had 2 weeks of doing nothing, for example, and then you just all of a sudden ramp it up, that would be a recipe
as short as 2 weeks.
Many overuse. Yeah, 2 weeks is But it's a recipe for many overuse injuries. Shin splints is one of a number of them.
So you almost need a pre-season for a pre-season.
Yeah. Or you just keep doing a little, like you said, relatively resting. Yeah. Maybe we don't stop and do nothing at all. Maybe we're still doing something, but we're doing a lot less, and then we're introducing slowly. But the other thing is they're all extrinsic factors. They're factors that are outside of our body. But then there's our own mechanics as well. So our biomechanics, and that's a very, very important one and hugely individual. So when we were saying before, picking the right shoe for the foot type, picking the right shoe for the activity. So that's really important because that's, as we said, it's, at its essence, impact. So what we're trying to look at here is how do we reduce that force, the loading? How do we reduce the stress on the bone? And so when we look at people's mechanics and foot types, it's, I'd say, more associated with people who pronate a lot more or pronate excessively. Also people who are very supinated, so they have got a very high arch foot, for example, which is typically not as, a stiff, high arch, rigid foot is typically not as efficient at handling force and stress as a foot that's more adaptable. For the same reason as we're saying with a hard, running on a hard ground isn't as, So I think looking at someone's foot type and definitely correcting the mechanics if we needed to. So their foot posture, their foot type, foot posture. We look at how they're running, and we can sometimes go down the path of arch supports or insoles, orthotics, that sort of thing, in combination with the shoe. And those two are our mechanical sort of interventions. The shoe, which is the first thing that hits the ground, and then you've got the insole, which is correcting your foot posture. That way we can put you in the most efficient position while you're running or while you're performing your activity, even walking, whatever the case is in that particular presentation. And then we start looking at, okay, well, now that we've maximized the efficiency intrinsically, how do we then go about we then go about adjusting those other factors around that? So your training loads, do we introduce cross training, for example, where you're still training, you're still maintaining your cardiovascular fitness? Because when we're talking about elite athletes, we're talking about training. But when we're talking about the weekend warriors and our everyday sort of population who are, a little bit athletic, sometimes they're athletic for different reasons, right? Not for a contract. They might be athletic because it's their mental health escape. I go running because I need to clear my head. I go walking because, I've got type 2 diabetes, for example, and I've got to keep the blood glucose levels down by implementing this treatment program. And if I have shin splints, I can't, do that. And then I've got these. So for these people who we have to keep active, we then introduce things, like cross training, or we might have, we still need a way of doing something, but we need to manage that load. And that's where I was saying before, it's a very individual approach. It's depending on where they are in the pain level or where they are in the spectrum of the injury itself.
Gotcha.
And where they are in lifestyle.
Yeah, I was going to say, so to wrap that up in, I guess, sort of like the next 2 minutes or so, I guess these things I've learned. One, we don't know entirely what shin splints are exactly. Could be a number of different things. Having said that, we do know how to treat them. And the good thing about the treatment is there's actually quite a lot of options. So there is definitely that opportunity to find something that works, and that it doesn't necessarily mean that we have to step back from what the training is that we're doing. It's more of a tuning things because you've got so many variables out there that you can work with. So on the whole, if you do get shin splints, you could certainly have something a lot worse than shin splints, couldn't you? Yeah,
absolutely.
With regards to not, I'm sure they're very painful for some people, but they're definitely something can be treated.
Definitely, yeah.
And treated.
Stretching, strengthening, exercises. Definitely things, a lot of things that people can do at home as well. So you can find there's, there are pain packs for shin splints. There are multiple exercises online and things like that you can get. But then if they need professional help or professional guidance, one is if the pain is pretty excessive, it's limiting motion. If it doesn't fit that narrative, it's just like you said, woke up and had it one day, or you're getting a lot of tightness and things like that, and it's not in that same area, that's when I'd seek some advice.
Gotcha. Excellent advice. And just everybody remember, Sam does have those pain packs online. What's your URL again?
Painpacks.com.au.
Excellent.
Where you could find those. Yeah.
Thank you, Sam. Thanks for that. And we'll talk to you next time.
Catch you then.
See ya.
Thanks.